Tumour, ex-professor of physics. She has lots of comorbidity with diabetic, osteoarthritis, severe on right knee, and dyslipidemia. Her family history is very strong. Younger sister had breast cancer diagnosed at the age of 50. Past medical history, she had total abdominal hysterectomy without having bilateral self-lipophorectomy, and she had cataract surgery. She don't have any issues, and she didn't take any OCP. In early 2020, she felt a mass with mild pain in her right breast and went for evaluation. On examination, there is a 2 into 2 centimeter mildly tender, less mobile mass in upper outer quadrant near the right axilla. Skin and underlying structures are free, axilla free. Left breast was unremarkable. Investigation done for mass, and mammogram showed a 18 into 14 millimeter mass in the same region with at least 3 axillary lymph nodes, which by that category was 5. And biopsy also 5 in this case. Bone scan was negative. Abdomen was evaluated with ultrasound. There is no abnormality detected. Chest X-ray done. That is normal. Core biopsy shows infiltrating ductal cell carcinoma, grade 3, and immunohistochemistry for ERPR was positive strongly. HER2 was negative. This is the pre-op MRI, and the mass is as well as the axillary lymph node was visible in the MRI in all sections. So clinically, she was diagnosed as a T1N1. She underwent surgery, white excision, and of the right breast left and axillary clearance after having frozen section confirmation on early March of 2020. Histopathology also confirmed the infiltrating ductal cell carcinoma, grade 3. 2 lymph node were positive, and tumor size was 1.6 into 1.2 centimeter as per our radiological guidance. All resection margins was free, and pathologically it was T1N1 disease. Due to her adjuvant treatment and the COVID situation arose, and she was only 3 daughters, most of them not here, and she was not very keen to start any chemotherapy. So oral capecitabine was started in the COVID situation, and 6 cycles received up to September 2020. Still radiotherapy was not planned. She was not received. She was planned for radiation. And on post 6 cycle evaluation, her marker CA15.3 gradually raising, and highest was in 47, which was 22.8 earlier. She was quite a bit healthy, and local examination July 2020, there is PUD orange appearance, no palpable mass in the operated breast, but edematous. Left breast found unremarkable. And for her evaluation, some investigation also done. Breast ultrasound also suggestive of architectural distortion, and skin thickening. Rest of the findings are normal. Left breast, there is no abnormality on July 2020. And another CT scan was done on September. There is no local recurrence or residual mass, but post-treatment edematous and inflammatory sequelae was found on the right breast, and there is possible granulomatous mass in the left adrenal, and that was recommended for regular follow-up, no liver, lung mets, and bone mets. For her edematous brain and PUD-RS, MRI was also suggested. That was done in October, which shows diffuse subcutaneous edema in right breast, no focal mass lesion seen, normal right axilla. But there is a focal change subareolar region in the left breast and left axillary lymph node, which category by that 6, as stated by the radiologist. This is the image of the right breast. Unfortunately, I cannot show the opposite breast image, and photo was taken with permission. This is the post MRI that was done in October. I think where there is a lymph node here, and there is a little change over here in this all sections, left breast. So question and discussion from my end. What will be the expected post-operative change in case of lumpectomy to exclude T4 disease? What will be the further investigation in case of suspected PD orange appearance despite the MRI of this particular case? What will be the mode of investigation for evaluation of the left breast MRI findings? What signifies the increased marker? And should we go EBRT with boost in situation of the left breast? Thank you all.
So I think she should be the case for genetic counseling and testing, if possible. This is one thing. And regarding the surgery, she had lumpectomy and axillary dissection. And it is surprising to me that in axillary dissection, only 2 out of 4 lymph nodes. This is very unclear to me. Only 4 lymph nodes excised and only 2 have metastasis. This is questionable to me. Though due to COVID situation, she has received oral chemotherapy to combat the situation. And next thing is that in the left breast, she had a Byret 6 lesion in the subauricular region and gradual increasing titer of the CA15-3. So ultrasound-guided core biopsy may be needed from the left breast subauricular region. And lastly, if feasible and patient can afford, go for PET-CT scan. This is my observation.
Sir, I have a question regarding the operated breast edematous or PD orange appearance. What will be the expected chance in this case?
It could be because the lesion is the outer quadrant, nearer to the axilla, and simultaneously axillary dissection done. So there is double problem in the lymphatic channels.
Okay.
So this is one thing. And there is subdermal infiltration, maybe, we do not know, there might be. So skin biopsy may give the real situation to exclude the infiltration or not. This is my thinking.
Yeah, I agree exactly with the skin biopsy to prove inflammatory breast cancer, given the peau d'orange. I think I would really try very hard to make that diagnosis pathologically with a skin biopsy on the right. I do agree that the left side likely warrants further workup. It's interesting that you gave her adjuvant capecitabine rather than chemotherapy. I think so when I was a fellow in training, a rule of thumb that I've carried with me is to estimate the risk of relapse or a breast cancer event after surgery. And I've used 10% per centimeter of tumor and 6% per lymph node. So if you use that for her in the absence of any kind of genomic data, her risk of a subsequent event is at least 30%. Now, you could take that down by half if you just gave endocrine therapy, which for hormone-positive breast cancer is probably going to be the most useful part. I would have given her chemotherapy, but if she had opted against it or during COVID it became impossible, I probably would not have given her capecitabine. I would have started her on endocrine therapy. And try to reduce her risk by half, and then also try to get her to radiation therapy as quickly as possible. Just so you know that there was a clinical trial that looked at capecitabine in older adults starting at the age of 65. That study of CAPE versus chemo, or AC specifically, showed that capecitabine, the volunteers who took capecitabine did much, much worse in terms of relapse, staying relapse-free. It was just significantly worse. So I'm not sure the benefit is there for capecitabine. If the option is not IV chemotherapy in a hormone-positive setting, then I would use endocrine therapy and radiation therapy alone. Now, in this case, this is a patient we may have considered, if her comorbidities were coming into the picture, doing an Oncotype DX to see what the genomic score or the recurrent the risk score was for her. However, recognizing as well that the more advanced the disease, the less data there is to really utilize it.
I have some comments about this case. About the right breast lesion, I think the lymph node dissection was not adequate because it was a grade 3 tumor and only 4 lymph nodes were taken out. So the oncologist might have asked for a review for the pathological staging of this case before going into treatment. And also about the left breast, the subareolar lesion should be excluded because it is a BIRAT 6 already stated. So a core biopsy would be, I agree with Prof Anwar that a core biopsy of subareolar lesion would be good for diagnosis of the left breast. And for the right breast, I think the pathological staging was not adequate for this patient.
Can I add one thing? Actually, when the patient was diagnosed that time, that all the centers was totally out of function, especially in COVID period. The pathologist didn't work at that at that time. Even the surgeon was not available, and during the COVID, starting the COVID period. So the patient cannot review the slides and other things. Regarding the Oncotag DX at that time, we cannot send the samples to outside Bangladesh because all the DHL and other things was especially totally disrupted in this COVID period. Even till now, we don't have the facilities to send the tissue samples to outside Bangladesh, especially to do the Oncotag DX or Mamma Print or OncoAssist, what we do actually from the neighboring countries actually.
Do you like to suggest the skin biopsy for the PUD orange appearance for the right breast lesion?
PUD orange, from which part you will take the skin biopsy? It's a large area of PUD orange. So which part will be more susceptible? If you can find one part which is a more thickened area or maybe suspicious for malignancy, spread of malignancy, then you can do a skin biopsy from that area. Or otherwise, I think it could be due to the because of the surgeries from some lymphatics has been cut down and all these things. You can, I think you can follow up this patient for further for some. And then if otherwise, if you find any significant area, you can do skin biopsy to rule out.
But I think there is no specific area where you can do the biopsy because it's totally the area is inflammatory ones. There is no lesions there actually. So we are planning in that case, as Dr. Don Dizon is there, we are planning to do to go for irradiation, especially for the breast, and also to treat the patients with a hormonal manipulation, as we had a year positive case, positive in this case.
Because the CT scan finding revealed there is a adrenal hypertrophy or adrenal mass. I think that has to be excluded for why there is a problem.
Yeah, radiologist told us to keeping the patient to follow up, especially for the adrenal.
This is very difficult because she diagnosed case of malignancy, and how we only follow.
Radiologically benign, sir. It looks benign granulomatous lesion. Radiologically describe the adrenal mass like that way.
I think ideally the BRCA test is to be done. That is genetic counseling and testing. And another thing is that as there is lymphedema, we don't know what is the reason behind this. There is no focal area. So why not to do PET CT scan? As because skin biopsy, from where we shall take this? PET CT scan gives some clues. Regarding, this is the comments regarding the diagnosis. And then further will depend upon these reports. Thank you.
Yeah, especially in the PET CT, if there is inflammatory lesions, especially in the breast, I don't have that much experience. Even inflammatory lesions is due to lymphatic infiltration, especially what we know. Actually, I don't know whether the inflammatory breast cancer can be well documented by the PET scan. I doesn't know actually. I think we can have opinions from the PET scan specialists whether inflammatory breast cancer will be well visualized with the PET or not.
Right. In this patient, if you recommend a skin biopsy, that should be full thickness skin biopsy, number one. Number two, in inflammatory breast cancer, skin biopsy is not a diagnostic way of diagnosing the inflammatory breast cancer. Rather, the underlying tumor should be biopsied with the core biopsy. That is the standard practice, number one. And the other point, as Professor Kamruzzaman said, the pure orange appearance is because of the tethering of the underlying lymphatic channels. It's not because of the skin infiltration. Skin infiltration occurs much later. It can be even visualized in naked eye. So biopsy, if at all, that has to be in full thickness. The better idea is to go for a core biopsy. And when there is pudiorange appearance, it implies that it is T4 disease. Nipple retraction, skin involvement, and pudiorange. These three are T4 disease. So it is a stage 3B disease. T4 means stage 3B.
If tumor block emboli is present, that can suggest that it is an inflammatory breast cancer. It is a protocol. It is in 2011. It is consensus in 2011. I have a paper on that. In a review paper on inflammatory breast cancer with AIMS Delhi.
Yeah, that's a good suggestion. I think you can. Somebody can try to take a skin biopsy so that intra-lymphatic emboli of the tumor emboli. Yeah, that is a good decision.
The case was T1N1 disease.
Yes, sir.
Wide excision and axillary clearance.
Yes, sir.
This is the typical case for Oncotep DX, but due to COVID situation, it is not possible in our country. Number two, this case should receive the radiotherapy, as it is a excision and with the axillary clearance.
This is a very wonderful session. Actually, we learned a lot about breast cancer management because Don Dizon has given an idea. Especially the Palace trial, and also he showed that actually regarding the two trials like the hormonal manipulation and capecitabine especially, and definitely we learned a lot from him actually, and we are using our local expertise here and also local facilities. What we are doing actually in all cases, all the individual cases, individual ones, and especially opinions from the individual oncologists. So we are getting some ideas about the managements, what they are doing actually in US and other parts of the world. And thank you everybody. And we really mourn because we lost our colleagues, Taposh Mitro, who is a very talented guy, and he is especially very academic. He participated in the last webinar on Friday, and we lost him on 24th October. We definitely pray to the Almighty so that his soul can be kept in peace. Actually, thank you all.